Welcome to the last live case demonstration in Power Up Endo's 90-day Super GP training program. All of our cases and all the information and framework that I've put together for you has led us to this point so that we can present to you that big bad boss upper molar with an MB2. I'm going to show you exactly how I want you to treat these cases, exactly how to discover that MB2, how to instrument it, and ultimately how to fill it along with the remainder of the root canal system. So let's get right into it. So this patient was referred for tooth number 3. She's a middle-aged female, and she had a what appeared to be a relatively shallow MO composite that was placed. She initially had this filling done 2 months prior and had some cold sensitivity for a couple of weeks, and that eventually died off. And then now she's left essentially with pain that wakes her up at night and just a general throbbing pain from time to time. And so when we look at the bite wing radiograph, we can see that the restoration doesn't appear all that deep. And then when we go ahead and look at the periapical film, we still can't tell that it's a significantly or a very deep restoration, and you can't really see lesions at the apical regions or at the apices of these roots. When we do our clinical testing, we discover that tooth number 3 is found to be negative to cold, positive to percussion, and positive to palpation. So that tells us that our endodontic diagnosis for tooth number 3 is pulp necrosis with symptomatic apical periodontitis. We have a favorable prognosis, and our treatment plan, as you can imagine, is non-surgical root canal treatment. So we're going to go ahead. This patient also needed a little bit of intrapulpal anesthesia. You'll notice even sometimes on your necrotic cases that you can have some pulp tissue that's resistant to dying off. It takes longer for certain nerve fibers to die off. That's actually the C fibers inside the pulp tissue. So don't assume that because you have a negative cold test and your pulp is necrotic that your patient won't feel anything and thus won't need any anesthetic. This is a perfect example of a situation where the patient had appeared to be to have a completely necrotic pulp, but still had some pain even after giving our traditional anesthetic. So anyways, let's get right into it. So we obviously anesthetized our patient to start and went ahead and placed our rubber dam isolation with clamp 13A for the upper right. And now we're just doing our occlusal reduction with the chamfer diamond, as we do in all teeth that haven't had a crown preparation, or at least all posterior teeth. And as usual, we're just lowering the cusps a little bit, and then we're going to go ahead and proceed to our access preparation. All right, so this tooth is a little bit small in terms of the mesiodistal table without a very pronounced oblique ridge, but the same rules are in effect where we're trying not to go too far into the area of that oblique ridge. And this number 4 high-speed surgical length round burr is used to do the majority of the access preparation. So we're slowly making our way into the pulp chamber of this case, and you'll get a sense for the general outline form. Also, some cases you'll find that the dentin is harder than in other cases, and you already know this, right? But don't be surprised if you have to go at it longer to make your way into the pulp chamber. The important thing is you stay in the area where you're attempting to keep your access preparation confined to, and you just take your time with the brushing motions. Okay, you'll make your way in. Also, because we had an open pulp chamber, as in our last upper molar case, we expect the burr to drop into the pulp chamber, assuming you're in the correct spot, like you see here. So, in this case, the palatal area is to the top right, and the buccal area is to the bottom. And it's the same kind of outline form as our last upper molar, a rounded triangular form, if you will, with the narrower part closer to the palatal. And we're almost at the pulp chamber. You'll notice that the burr drops right there. We have a little drop right into the pulp chamber. And there's still there's a tiny bit of bleeding because not all of the canals are completely necrotic. So this is, if we were to examine this histologically, we'll probably find that this is a partially necrotic case. So now we're taking our endo-Z-burr and we are smoothing out the internal walls of our access preparation and just making sure that we have visibility and the ability to reach all of the canals. So in terms of access preparation, you've probably noticed that your textbook access preparation isn't going to be suitable for every single case. It's all dictated by the location of the canals. So that's why you want your access preparation to be initially on the smaller side, and then you want to expand from there and really take what the tooth gives you. Don't make your access preparation smaller than what is anatomically needed, and obviously don't make it any larger than what you need. But you need good visibility, you need a good opening so that you can completely disinfect the root canal system, and you can't do that with a tiny little pinhole access. But at the same time, you don't want to structurally weaken the tooth, right? So there's a fine line, and every access preparation is going to look slightly different. But this endo-Z-burr is fantastic, as you already know, because it's non-end cutting and it's only going to cut on the sides of it, and so you're less likely to have a perforation because you're not preparing apically. And we can already see the canals there, and we're going on to our canal identification. All right, so we have our ProTaper Gold SX orifice opener, and we're just passing it into the mesial-buccal canal to start. And now we're going to be going into the palatal canal. And that palatal canal is actually the canal where our patient complained of a little bit of discomfort when we passed that orifice opener into. So we'll end up giving a little bit of intrapulpal in that region here in just a moment. But a little sodium hypochlorite to start cleaning out that debris internally, and this way we can start to orient ourselves inside the case. And now we're going ahead and putting our orifice opener into the distal buccal canal. And as always, once we start to penetrate into the canal, we're going to brush to open up that canal orifice. And remember, we're always going to brush away from the furcations. So in the mesial buccal canal, you're brushing in the mesial buccal direction. In the distal buccal canal, you're brushing in the distal buccal direction. And for the palatal, in the palatal direction. And you're doing that to just open up the coronal third of the root and to really open up your canal orifice. Some more sodium hypochlorite, and that looks good. So we're going to introduce our 10 file in the mesial buccal canal first to get our working length. So we've got the 10 file in, we're attaching our apex locator clip, and we're going to start getting our measurement. We're going to find that the working length for this mesial buccal canal is 19.5 millimeters. And I'm just relaying that to my dental assistant so that she can record it. Very good. And now into the distal buccal canal. Notice the pre-bend on those files. Like I mentioned, it's a subtle bend, just leaning on your metal mirror to create that subtle bend with your fingers. They have little instruments to create bends, but that's not really needed. That's just a nice to have, if you ask me. But that's going to make it much easier for you to place the hand files into the canal that you're attempting to, because you can just subtly turn the file to move the orientation of the tip as opposed to really, turning your hand a whole lot. And now into the palatal. And now we're going to go ahead and introduce our 15 files so that we can take our working length radiograph. So again, in our mesial buccal, we're at 19.5 millimeters. In our distal buckle, we're at 20 millimeters. Remember, that's always, or typically, a little bit longer than our mesio buckle. And then our palatal, we're finding to be 19.5 millimeters. We're going to place all three 15 files in and take our working length film. Now into our distal buckle. Remember, you want to place these files in decreasing order of awkwardness in terms of their position. So typically we do the palatal last because it gets more challenging to put hand files in the case after you've got other files already sitting in other canals. So you want to make the easiest one to place last. So we've got our working length film there. We can see our apex locator gave us good readings. We are right to the lengths that we want to instrument to, and we're happy with those lengths. So now we're going to remove our hand files and we're going to proceed to the instrumentation phase of the procedure. So first we've got our Vortex Blue 1504 rotary file, and we're going to go ahead. A little tip here is in an effort to decrease the amount of times that you're adjusting the rubber stopper on the canals as you pass from canal to canal. I always start with the mesio buckle for upper molars, but if another canal is the same length, I'll instrument that canal first before proceeding to the distal buckle, which would normally be the second canal that I instrument. So in this case, the mesio buckle and the palatal were the same length. So you'll notice in the sequence, I go from mesio buckle to palatal and then to distal buckle, only so that I don't have to keep adjusting the stopper. So that was the 1504 in all three canals, and now we're going ahead and irrigating with our half-strength sodium hypochlorite and just working our way up the ladder. Here we go. Now we got our 2004 Vortex Blue rotary, first in the mesio buckle, all the way to length, and then into the palatal. Good. And now into the distal buckle. And when I placed the file in the palatal canal, that's when the patient was complaining of a little bit of discomfort. So here we're going ahead and doing an intrapulpal injection with our Septicane right into that palatal canal. And you want to seat it as deep as you can in the canal and really give it a good, half carpule or so. A little more sodium hypochlorite, and from here on out, the patient is now completely anesthetized, and it's a pain-free procedure at this point. So we're proceeding now on to the Vortex Blue 2504 rotary, first in the mesio buckle, then into the palatal. Very good. And then finally into our DB. And notice on that outstroke, I'm brushing, right? That's a great way to make space, and it makes increasing the sizes of the rotary files easier and easier. Back to sodium hypochlorite. We're making our way all the way up the ladder here. We're making good headway on this case. Now we're up to our 3004 Vortex Blue, first in MB. Then into our palatal, again, because they have the same length. Then I adjust my stopper, and I come back into the distal buckle canal. Remember, with every instrument and into every canal, we are wiping the hand file, or wiping the rotary file, placing RC prep on the tip, and then going into the next canal. You never want to introduce a file into a canal that hasn't been hasn't been wiped so that the flutes are nice and clean. Good, more sodium hypochlorite. We're actually almost done instrumenting our main canals. Here we have a 3504 vortex blue. We're going to take that into the 3 canals, and then we're going to go ahead and do our searching for the MB2. In the palatal. And then in the distal buccal. And as it is in many cases, the palatal canal here was found to be a little bit larger than the other 2 buccal canals. So we're going to go ahead and prepare the palatal canal up at least one more size. So we're going to go up to a 40 in the palatal. Again, more sodium hypochlorite. You can see how the constant rinsing with the sodium hypochlorite allows for it to soak in the canals for as long as possible. That's critical for your necrotic cases. So we've got our Vortex Blue 4004 going into the palatal. Very good. Yeah, the allowing for the sodium hypochlorite to soak in the canals has a profound effect. So not just is concentration important, but also volume is important, as I mentioned to you, and as well as time that the hypo has had a chance to sit in the canals. So now that we've instrumented our main canals, we're going to go ahead and search for our MB2. So you'll notice I'm going to draw for you a line, just like we did in our last live case demo with the upper molar without an MB2. I'm going to draw for you a line that's connecting the mesiobuccal canal and the palatal canal. And then you're going to take a line that's perpendicular to that line from the distal buccal to the line connecting the mesiobuccal and palatal. And just mesial to that point of intersection is where the MB2 normally is. In this case, it's slightly closer to the MB canal, and that's because those canals merge, but that's your starting point and that's where you're looking. If you actually look really closely, you'll notice that there's a little fin just palatal to the main MB canal, and that's actually where the MB2 is going to be located. All right, so we're going to go ahead and open up that area with a round burr. This is a number 2 surgical length round burr, and we're just going to unroof some of that dentin that's covering up the canal orifice for the MB2 so that we can gain access to it. Remember, there's oftentimes a little bridge of dentin that's covering that MB2 orifice. And so we have our Endo Explorer, and we're just trying to pinch our way right into that canal orifice, which you can feel with the Endo Explorer. So now we're going to take our ProTaper Gold SX orifice opener and just peck right into the area of where that MB2 should be, and we're going to find that it wants to drop right in. So not too much trouble here in finding the MB2. And with your necrotic cases, you're not going to have the help of a bleeding canal to help you discover the MB2. So it's a little bit more challenging for your necrotic cases, but nevertheless, if you know where to look, you'll be able to find that MB2. Oftentimes, the case goes by faster when there is an MB2 as opposed to when there isn't, because when there isn't, you're looking, you're doubting yourself, and so there under high power magnification, we can see that orifice. So we're going to introduce a 10 file to length, and we're going to try to make our way down to the apex. In this case, a 10 file did not want to reach the apex, so we're going down to an 8 file, okay? And with these small hand files, remember, your C files are really, really advantageous because they're a little bit stiffer and they can break through little tight spaces in calcified canals much easier. So now that 8 file is making its way down. So we're attaching our apex locator, and we're going to discover here that the MB2 is 19 millimeters. So I'm re-bringing in the 8 file, and I'm just trying to prepare that MB2 and create a glide path for some rotary files. So I'm rechecking the length, just confirming it, and notice the way that I'm using that watch winding motion to make space. Remember, we're trying to create a reproducible glide path for the rotaries. So we'll work our way up from the 8. You can see that it's a very, very tight canal. So now we're going up to our 10 file again, now that we've made a little space with the 8 file, and we can see that that's going down all the way. And we're going now up to size 15 with the hand file and just working our way and making space. And we can see that now we're starting to have the room necessary to introduce some rotary files into that MB2. Again, right in, just trying to create some lateral space. These MB2s oftentimes are very, very tight canals. And so what I'm going to be doing here is confirming the working length by placing a 25 in the MB and our 15 in the MB2, taking a film. And so now we can see that the MB2 actually appears to merge with the MB1. We'll find that it doesn't completely merge, because if it did completely merge, you wouldn't be able to fit both of the canals to length all the way in, especially when one of them is a nice fat 25 file. But they're very close to each other. They're probably right. The MB2 is probably either right behind or in front of the MB1, probably a little bit behind, and just passes right alongside of it, okay? And so now we're gonna go ahead and instrument our MB2 with our rotary files, now that we're confident that we have a nice reproducible glide path present, so that we can proceed and pass our rotary files into that tight little canal. So we're going to start with our 1504. We're just going to need to irrigate a little bit before, just so we have a nice area to work with. And here we go. Here is our 1504 Vortex Blue in the MB2 canal. And you're going to see that it wants to go all the way to length without too much trouble. With these tight little canals, you have to be very, very careful to have a reproducible glide path, okay? So 15, if you feel more comfortable going up to a 20 hand file, by all means do that. But make sure you have a good path before you start to introduce your rotary files. You don't want to separate a rotary file at this late in the game after you've worked so hard on this case, right? So a little irrigation, and now going up to our 2004. Perfect. And you can see that file wants to go down without too much trouble. Okay, more sodium hypochlorite as usual. And you can see that's starting to take shape now. Now we're going in with our 2504 Vortex Blue. A little bit of a brushing motion on the outstroke as usual. More hypo. Then up to the 30. Good. Little rinse. That looks good. And now up to our 35, which is going to be our last rotary file that we're going to take to length in the MB2. Perfect. So now we're going to go ahead and move on, now that we've instrumented our MB2, and proceed to the disinfection stage of the treatment as usual, where we're going to pass a lot of sodium hypochlorite through all of the canals. Remember, that hypo has had a chance to set and soak for a long time in the main canals, and so now we're going to go ahead and use a lot more. So we're aspirating out, and then we're going to go ahead and introduce the 17% EDTA solution. So that's our EDTA, and we're going to put that in all 4 of the canals and let that soak. Remember, we want to let that soak for 60 seconds. This is a portion of the case that I did edit, because I'm not going to have you wait for 60 seconds. But that was 60 seconds. We're aspirating out, and then we're going to go ahead and utilize our last flush with the half-strength sodium hypochlorite. Remember, this is important because the EDTA is going to remove the smear layer, and then the last flush with the sodium hypochlorite is going to penetrate into those exposed dentinal tubules. It's super important for your necrotic cases. And now we're going into our obturation phase and reaching for our ProTaper F2 paper points. Those are the red ones, so that we can dry the case and start with our obturations. Good. And then the palatal. Perfect. And now we're going to reach for the Brasseler Bioceramic BC Sealer. We're going to bend the tip a little bit, and we're going to start filling these canals with the sealer. Always with a passive fit with the sealer tip so that we don't squirt sealer out of the apex. Very good. And then finally, our big palatal canal. We're going to remove the sealer tip and start dunking our pre-measured gutta percha cones that have been crimped at the appropriate length. So first, the mesiobuccal. And as usual, we're going to obturate with gutta percha cones one size down from the last rotary file that we used so that we can have enough space. And now our MB2 cone will be introduced. And I'm going to find that the MB2 cone doesn't want to seat all the way to length. I couldn't see the orifice because it's so close to the MB1, so I just used a little perio probe just to remove some of the sealer so that I can actually see where I'm placing this gutta percha cone. But this cone doesn't want to seat very far, so what I'm going to do here is remove some of the sealer with a hand file. So there's a 35 hand file, a clean one, and I'm going to go ahead and just go into that MB2 just to make room and remove some of that sealer so that we can introduce the gutta percha cone to the appropriate length. And now that that sealer has been lessened in the canal, we can seat that size 30 cone to the appropriate length. Still a little bit short because it does merge with the MB1, but at least now at a reasonable length. And here's our 30 cone in the distal buccal all the way to the crimp. And then finally the palatal gutta percha cone, which remember we prepared to a size 40, so in the palatal, so we're using a 35 cone for that palatal canal, which is the green. And there's our cone fit radiograph. We can see the cones are at the perfect lengths. The MB2 and the MB1 are right on top of each other, but we're happy with that cone fit and we can proceed with the remainder of our obturation. So we have our System B heat tip that we're going to go ahead and sever the gutta percha cones right at the orifice level. I know it's a packed house here with all these cones, so just be careful to just sever at the orifice level and do your best to not pull out any of the gutta percha cones. Good. And you want to leave yourself with just enough gutta percha to have room for your compaction, but not so much that there's a whole bunch of excess. Remember, this is the System B tip with the fine medium 08 Buchanan heat plugger. That's the standard heat plugger that we use for basically all of our cases. I wouldn't bother outfitting your obturation unit with more than that size. That's kind of a universal size. And this is looking good. And it's nice to only leave enough gutta percha in the mesiobuccal roots in terms of the MB1 and the MB2 canals so that you can differentiate the two canals in the event that this case ever needs to be retreated at some point. Hopefully never, but if so, you know, hopefully not till decades and decades later. Good. And you can see how that's starting to look the way it should. As I'm beautifying the inside here, you know, I think it's a good idea to just point out that, you know, you can tell this case Doesn't need to take a whole lot of time, assuming you know what you're doing and you follow the framework that I've put together for you. It's the most predictable way, in my opinion, to go about treating your endodontic cases. That way you have a roadmap and you know exactly where you're going and the steps needed to get from point A to point B. A lot of water here with an air blast just to remove the excess sealer and any flakes of gutta percha, and then some last final touches with the Buchanan heat plugger. And we expect this patient to do very, very well. You don't need to necessarily prescribe antibiotics for this case. I know this was a one visit necrotic case. You may opt to perform your necrotic cases in 2 visits, but I feel very comfortable utilizing this framework and this level of disinfection, treating these cases in a single visit. And there you have it. So I'm going to temporize this case. If you feel comfortable and you want to go ahead and place your core buildup, by all means, go ahead and do that. It will only take you a few more minutes, and then you have a very, very profitable patient visit that doesn't require the patient to return to your office multiple times. It doesn't require, a bunch of chair time for all those visits. Take advantage of the system that I've put together for you so that you can thrive. I'm placing the sterile sponge and temporizing with Cavit. So the Cavit's being placed, and then we're going to go ahead and burnish that down with a moist pellet. And there you have it. I'm just going to remove the rubber dam clamp now, and we'll take our post-operative radiograph, and you can see there that that looks exactly how you would want your cases to finish. You can see the MB2, it is a separate canal, and it kind of merges in the middle of the MB root with the MB1, and the root fillings are at the appropriate length, the appropriate density, and everything looks great. All right, that is it. That is the last live case demonstration in the main course. There is a little more case demo in the bonus stack, but this was that big bad MB2 upper molar that you've been waiting for. Even if you decide you don't want to treat these upper molars because you're concerned about the MB2, you have a ton of endodontics that you can treat in your practice. And if you feel comfortable only taking it to a certain level, by all means, go ahead and do that. If you feel like you can handle these more complex cases, then, again, take advantage because you can do this. You have the ability. Endodontics is really no more challenging than any other phase of dentistry. I hope you feel empowered to tackle these cases and power up your endo game en route to becoming a super GP. There you have it. I'll see you guys later.